Good evening, sir. Good evening, respected professor and my dear students. I welcome you all to another session of DNB online academic activities from RISA. Today we have ongoing sessions on comorbidities and anesthesia. Today we'll be discussing with professor the topic on diabetes mellitus. Over to professor and students.
Thank you. A very happy new year to all of you, and a very successful year too for those who will be having their exams this year. Nowadays we get patients with comorbidities even at a very young age. Earlier days when we were postgraduates, diabetes, hypertension, ischemic heart disease were all considered as diseases above the age of 45 or 50. People less than 45, we never used to worry about these comorbidities. But the pattern of life, lifestyle, work pressure, and the habits, all these things have made people even at the age of 25, 30 come with all comorbidities when they have to undergo some surgery. So I thought we'll discuss the comorbidities one after another. This is the first of the series, which is very common nowadays. Every second patient you see in your pre-assessment clinic is a diabetic patient. So we should have a very clear concept of how to deal with these patients when they come for surgery. Now my first question to you is, all of you who have passed your MBBS, what do you think your how much importance was given to this topic on diabetes mellitus as an undergraduate? How much importance was given during your teaching days by your professors in medicine? Do you think you got a fairly good idea about the pathophysiology and how to manage a diabetic when they come? Can you share your experience? You think you were taught or given more importance to diabetes in your undergraduate curriculum? Or was it more for valvular heart diseases and congenital heart diseases and other rare oncology topics? Vidya, Prashad,
It was more for valvular heart disease and congenital heart disease, sir.
Yes.
Not much on.
Not much on hypertension, not much on diabetes, not much
No,
on
sir.
fever, causes of PUO. So we had a professor of medicine who used to give a PUO as a case for examination for the when you go to the medical OP. And he used to say, if you know how to treat a PUO, you are the best doctor because you will be getting these cases very often compared to a mitral stenosis or an aortic regurgitation. So that score, I just want to make sure that you all have a very clear concept of the basic pathology of diabetes, and you should be a good physician. Treat a diabetic patient if you happen to see one in the absence of a diabetologist or a general physician available. You should act as a physician to take decision to treat the patient appropriately and know what are all the recent concepts and guidelines that are being given for treating a diabetic patient. So with this, again, this is going to be a sort of interactive session so that we can find out how much of understanding you have in this subject. So let me straight away go to share the screen. Are you able to see the screen visible?
Yes, sir.
Yes, sir.
Okay. So this is the topic diabetes and anesthesia, out of which, first of all, let me give you an overview. What are all the things you have to know about? First thing you have to know is what is the definition of diabetes and how, when will you say a patient is a diabetic? What are all the types which are very commonly asked in the exam also? Then what is the pathophysiology and what are all the biochemical changes due to excessive glucose in the body? called glucotoxicity, and what clinical features, which systems will get involved, and what are all the effects, and what investigations you have to do when you get a diabetic patient with regard to cardiovascular system, nervous system, renal, airway, and how much control of glycemia has happened, and what is the treatment the patient is undergoing. Pharmacological agents which are commonly used, like oral hypoglycemic agents, or all about insulin. And you must know what long-term complications or end organ effects this disease produces in the cardiovascular system, in the nervous system, in the kidney, and in the metabolic status. And how do you treat the complications, especially DKA, which is often asked in the examination, both in theory as well as in practice. And finally, how we are going to manage this patient in the pre-operative, intraoperative, and post-operative, including the monitoring and control of blood glucose and how to use the insulin if needed. So with this in mind, the first question is the etymology of diabetes mellitus. Why this name, or how this name diabetes mellitus has been given to this condition? Can anyone give the answer for that? What is the meaning of these two words, diabetes and mellitus? There is such a big silence. I thought you will all be rattling off the answers. At least tell me of which language these two words originate from.
Probably Latin, sir.
Both Latin, or one is Latin, another is Greek?
I'm not sure, sir. Just a guess.
Greek, sir. Diabetes is Greek.
One is a Greek word, another is a Latin word. So it is derived from both Latin and Greek words. The Latin word is diabetes, which means siphon or pass, or pass out of your body. And the mellitus is a Greek word which means honey-like, mellifluous. You always use in English the word mellifluous. The song was very mellifluous to the ear. So mellitus means honey-like. So passing sweet urine. That was the meaning of this word diabetes mellitus. What other diabetes you have? What other type of diabetes you have?
Type 1 diabetes and type 2.
No, I'm not asking about the subdivision of diabetes mellitus. Any other diabetes you have?
Diabetes insipidus.
You have another thing called diabetes insipidus. What does that mean? What is the word insipid means? It is a pure simple, we have the same usage in English also. Insipid, tasteless. Okay. So when a person passes a lot of quantity of urine, which is tasteless, which does not have any sugar, it is called diabetes insipidus. Okay. So when do you get, what are the types of diabetes insipidus? All of you know the diabetes mellitus, you have 4 varieties or types. But
central diabetes insipidus and peripheral diabetes insipidus.
Central and renal or peripheral diabetes insipidus. Very good. What does it mean? What is the pathology in diabetes? Because sometimes examiners may suddenly ask you about the associated condition, because the word diabetes is there in the other condition also, diabetes insipidus. You said correctly, there is a central and a peripheral or a nephrogenic diabetes. It's called central diabetes insipidus or nephrogenic diabetes insipidus. What is the basic pathology in that?
In central, there will be decreased or no production of ADH from the hypothalamus.
Very good.
The nephrogenic, there is resistance in the peripheral ADH receptors.
Excellent, excellent. It is with regard to the hormone, antidiuretic hormone. Just like diabetes involves insulin as a hormone, pathology is lying with the insulin. Whereas in diabetes insipidus, the hormone, antidiuretic hormone, that is the one which is not functioning properly. So it is like type 1 diabetes is central diabetes insipidus, where there is no production or very little production of antidiuretic hormone. Whereas nephrogenic diabetes is like insulin resistance, where your antidiuretic hormone has got resistance and it is not working at the kidney level, but the production of hormone is normal at the pituitary level. Okay, so just you have to remember this associated condition, which may be sometimes asked by the examiner. So diabetes mellitus. Now next question is, how can you define a patient or the condition as diabetes mellitus? What is the definition? This is the etymology, how the name was derived was the first question. It is derived from both Latin and Greek words. And what is the definition? When will you call a patient as a diabetic patient?
Person with fasting sample more than 110 milligram per deciliter and a random sample of more than 200 milligram per deciliter, whose HbA1c is more than 6.5.
Well, okay. So these are all the objective types of definition. But when you say it is a group of metabolic disorders due to absent or deficient insulin production, that is the correct definition of a diabetic state. Okay. So by objective method, when you test the blood glucose or HbA1c to brand as a patient as a diabetic patient, you need those values. But the simple definition of diabetes is it is a group of metabolic disorders which happen because of the absence or deficiency of insulin production. So the basic pathology lies with the insulin formation in the body. Either it is not produced adequately or what is produced is not able to perform its normal function. So it's a group of metabolic disorders. So even though the blood sugar keeps on rising, that doesn't directly hurt you, but it produces changes in the various organs and metabolism, which causes the complications. So it's a group of metabolic disorders due to absent or deficient insulin production is the definition of diabetes. Then how is diabetes classified? This all of you must be knowing. How many types are there?
Mainly two types, type 1 and type 2 diabetes.
Then just 1 second. Hello. Enapa? ஆமா. ஆமா. சரி, நான் நாளைக்கு பேசுறேன்ப்பா. இப்போ கிளாஸ்ல இருக்கேன், நான் காலையில் பேசுறேன். ஓகே. So it is classified into type 1, where there is a total lack of insulin, either due to the destruction of the production center, namely the islet of Langerhans, due to antibodies. What is the next type? Commonest type.
Type 2 diabetes.
Type 2, due to decreased production or resistance to insulin action. So this is the most common variety among the population of patients that you get. Type 1 is of course more of a genetic origin also, and type 1 you rarely come across, but type 2 is the most prevalent and common conditions which we come across. Type 3 is the gestational diabetes occurring in pregnancy, and type 4 is due to other causes like drugs or other metabolic, hormonal disorders like Cushing's and all these things. So these are the 4 types of diabetic patients that you can encounter. Of course, gestational diabetes is very common nowadays because of the pregnancy occurring quite late. People get married late and then start getting or try for a gestation at a late age. So by the time they plan for baby, many mothers become diabetic. So gestational diabetes is also on the rise. So these are the 4 common varieties, and out of which one is completely curable? Logically thinking.
Type 3,
Type
sir.
2.
Type 4. Type 4 is because type 3 gestational diabetic mothers are potential diabetics at a later age. So if a pregnant woman becomes a diabetic during pregnancy, which is called gestational diabetic, even though the diabetes may temporarily become normal after the delivery of the baby, they are potential diabetic patients in future. Whereas the type 4 caused by the drugs, that is a condition which is totally reversible, because if you remove those offending agents, then the patient may become normal. So the type 4, and of course Cushing's, if you treat it correctly with necessary agents, then that also can be reversed. Whereas the type 1 and type 2 are controllable but not correctly fully curable. So these are the two things that you must know. Now one more question is this: can you write this type 1, 2, 3 in Roman numerals instead of Arabic numerals? What we have written is Arabic. 1, 2, 3, 4 are all Arabic numbers. Whereas when you write Roman numbers, earlier it was written in Roman numbers. Like you put like an I for 1, 2 I's for 2, and 3 I's for 3, and then 1 and V for 4. You remember that?
Yes,
that is
sir.
how Roman numbers are written. That was the original way of writing the type. Why they have removed that? Okay, let it be a quiz question. You just think over it and tell me the answer later. Okay. So now earlier it was written in Roman numerals. Now they have switched over to Arabic numerals, and you tell me the reason why that has been done. Right. Now coming to the next question, what are the complications of diabetes? How can you classify the complications or describe the complications of diabetes?
So it is divided into macrovascular and microvascular complications.
Very good, excellent. The microvascular. So what are the organs that are affected in macrovascular? What are the organs that are affected in microvascular?
Macrovascular, heart, brain, and the peripheral vessels. CAD, stroke, peripheral vascular diseases because of atherosclerosis. Microvascular is diabetic nephropathy, neuropathy, and diabetic retinopathy.
Excellent. Okay, so it can be broadly classified into microvascular and macrovascular. So in the macrovascular, it can be affecting the brain, producing a ischemic stroke or cognitive impairment. In the heart, it can produce high blood pressure, insulin resistance for a risk of coronary artery disease, and it can produce peripheral vascular disease like occlusion in the periphery major vessels, which many of you would have come across patients undergoing femoropopliteal bypass or femoral bypass or femoral-iliac bypass. All these things were done earlier days. Now, what is the alternate for that now? Supposing there's an occlusion in the femoral artery. Nowadays, do you find a femoropopliteal or a iliofemoral bypass being done commonly? What is the alternate, easier method which has now come into practice?
Embolectomy.
Whenever there is a block in a vessel, embolectomy if there is an embolus formation, but if it is an atherosclerotic narrowing, what is the current treatment available, which is much less riskier than open surgery?
Stenting, sir.
Endovascular stenting, okay, or even thrombectomy or endarterectomy. All these things are done endovascularly. So you find less and less number of patients coming for. Earlier days, about 10 to 15 years ago, it was very common. Every vascular surgeon will have 2-3 cases of femoropopliteal or iliofemoral bypass being posted in their list. But nowadays, after the interventional radiology has become so safe and effective, nowadays you find they are doing more endovascular procedures compared to open procedures. So these are the three major organs: BHE, brain, heart, and extremities, getting affected because of the macrovascular complications. The microvascular complications, the eye gets affected, you get retinopathy. which causes damage to the blood vessel and new vessel formation, which again ruptures. You get retinal vitreous hemorrhage, cataracts, glaucoma. All these things are more common. And you all are very, very aware of diabetic nephropathy, which is the commonest cause of end-stage renal disease, and patients coming for renal transplant at a younger age are all patients with severe diabetes who go in for nephropathy early. And neuropathy, where the nerves get damaged and produces all sorts of both sensory and motor system involvement, which is the neuropathy. So 3 microvascular complications and 3 major macrovascular complications are the complications of diabetes, which you have to remember. And look for all these things when the patient comes for your pre-anesthetic checkup. Okay. Now, next question is how glucose balance is maintained in the body. What is the mechanism by which we are able to maintain the glucose levels within the normal range in the body?
Conversion of glucose into glycogen storage, sir.
Very good. Whatever excess glucose you are taking more than what is required, it will be converted to glycogen and stored in which organ?
Liver and muscles, sir.
Liver and muscle. 2 organs. Both liver and muscles, they are able to store the glycogen. Okay. And so the glucose homeostasis is the maintenance of stable internal environment within the organism. And for that, you must require the glucose production and utilization should be in balance. So what you are taking and what you are producing in the body should be utilized. So there is no requirement for excess accumulation of glucose should not happen. So always the input and usage should be balanced. Then you can maintain a normal glucose homeostasis. And this picture will tell you how this normal blood sugar level, which is about 4 to 6, what does the mm mean?
Millimoles, sir.
Millimoles, very good. So how much is this equivalent to milligrams? How will you convert this? Because many textbooks in the Western literature will only give millimoles. They don't give milligrams. So you should all know, examiners also ask you how you convert the millimole into milligrams.
18
millimoles, 18 milligrams.
You have to multiply by 18. The millimole number multiplied by 18 gives you the milligram. So 4 to 6, 4 into 18 is 72. 4 into 6, 6 into 18 is 108. Correct? So 72 to 108 is the normal blood glucose range. So you must remember both the millimole value as well as the milligram value. So millimole number multiplied by 18 is milligram. And if you want to convert milligram into millimole, you have to divide it with 18. Then you will get the millimole. Okay. So this is the normal level of blood glucose. And whenever the blood glucose increases, then pancreas will release more insulin, which will facilitate more glucose uptake. And also it will promote glycogen formation and prevent what is called neoglucogenesis. What does this term neogluconeogenesis or neoglucogenesis mean?
It's a degradation of glycogen to form glucose.
That is glycogenolysis.
Forming glucose from other substrate like protein and fat.
Fantastic. So glycogen is conversion of glucose molecules into a multiple unit of glucose called glycogen. Polymerization. So glucose is a monomer. It's a single unit. So you combine, just like making a பூ தொடுக்கிற மாதிரி. You just when you get jasmine flower, what do? You tie it all with a string to make it into a chain. The same way, a single glucose monomer, when multiple monomers are united together to form what is called polymerization, it becomes glycogen. So whenever you want to use that, you have to break that and remove single individual monomer glucose for utilization. You cannot use glycogen as it is by the cell. Whereas gluconeogenesis is new glucose formation from substances other than glucose, as rightly said by amino acid or fat molecules. Okay. Whereas breaking of the stored glycogen is called glycogenolysis. So please remember these terminologies. So what happens? Glycogenesis is increased. That is more storage form of glycogen, and you prevent new glucose formation also. And then automatically the blood glucose level comes down. Then what happens? The balance is achieved. On the contrary, if the blood glucose level goes down, then insulin production will be stopped. And there are hormones which are released, which are called counter-regulatory hormones, like glucagon. And what are all the counter-regulatory hormones or anti-insulin hormones, which will raise the blood sugar?
Glucagon, cortisol, growth hormone.
Somatostatin, steroid, corticosteroids.
Catecholamines. So I used to remember that by the mnemonic C squared G squared. Two C's or two G's. Catecholamine, cortisol, glucagon, and growth hormone. C squared G squared. Two C's or two G's. So four hormones totally. Of course, somatostatin plays a very minimal role. So these four hormones are called counter-regulatory hormones, which increase the breakdown of glycogen to release more glucose into the bloodstream when the blood glucose level goes down, or it helps in formation of new glucose from the other substrate like amino acids and fatty acids. And then the storage also from the liver is released. The glycogenolysis causes this, and blood sugar value is restored. So this is how the normal glucose balance is maintained, which is a very, very basic knowledge all of us should possess correctly. Okay, this is a simple basic physiology. Now, how is insulin resistance caused, and what is the meaning of the word glucotoxicity?
Insulin resistor is caused by post-receptor insulin signaling pathways defectives.
Caused by
The post-receptor intracellular signaling pathway becomes defective.
Excellent, very good. And what does glucotoxicity mean?
When the serum glucose level crosses the renal threshold.
So that has to be renal threshold. The process, what will happen? It will be excreted in the urine. It will not be reabsorbed. That's what will happen.
Brain cells
No. So the reasons for insulin resistance are the insulin molecule produced by the liver, the pancreas, the islet of cells, Langerhans cells may be abnormal. Their structure may be abnormal. We will be seeing the structure later on. So there may be an abnormal molecule of insulin, or structurally it may be abnormal. There may be more of counter-regulatory hormone production compared to the insulin production, which is having a tendency, which we saw to, it is a normal response to restore the hypoglycemia into normoglycemia. But if the counter-regulatory hormones, like whenever a person is very much stressed out, constant tension, work job, that is the reason why nowadays younger people working especially in the IT industry and other stressful jobs at abnormal times, they become diabetic because of this reason. Their counter-regulatory hormone levels are much higher compared to the insulin production. It overrides the insulin production, which makes them become diabetic. Or there may be anti-insulin receptor or antibody may be present. So there may be an antibody to the insulin, or there may be an antibody to the receptor, which may be causing this problem, not allowing the insulin to have the normal action. And the fourth reason is there may be consistent production of cytokines, and there may be a target dispute effect. These are all more of genetic nature. So these are the four reasons that have been identified for insulin resistance. Now, this picture will tell you how this is being happening. Insulin resistance, whenever only when the insulin goes and occupies, this is the receptor for the insulin. So every cell has got a receptor for the insulin to come and occupy the receptor 4. And once that is there, the glucose transporters are stimulated so that glucose can enter the cell. Now here you can see a glucose transporter widely open, which is a protein present on the cell membrane. So this gate will open and glucose can enter into the cytoplasm of any cell that you want to have. Whereas if the glucose transporter does not function properly, it is not open, then glucose cannot enter the cell. So it will remain in the blood and it will start increasing in number. So you become hyperglycemic. So this is the mechanism. The insulin which is occupying the receptor is not able to open the glucose transporter for the insulin to enter, which should be normally happening. So that is how the resistance happens. And the glucose toxicity is described in this picture. Whenever your blood sugar is always high or you are in a state of hyperglycemia, then what happens? There is an increase in the amount of glucose which cannot be metabolized in the normal way. All of you should read about the biochemical method of biochemical steps of glucose utilization in the cells, which is very, very important basic knowledge all of us should have. So glucose, when it enters, can anyone describe the glucose metabolism in a summarized way, in a short step? How it gets metabolized, how it is getting utilized to produce ultimate aim of glucose uptake is, what is the ultimate aim of glucose uptake into the cell?
For energy production.
For producing ATP, which is the energy, isn't it? So what are how can you classify the utilization? Once the cell allows the entry of glucose into the cytoplasm, how does it get metabolized to produce the ATP ultimately? First metabolism, where does it happen? In the cytoplasm or straight away into the mitochondria?
In the cytoplasm, TCA cytoplasm.
So there is the first initial glycolysis happens in the cytoplasm in 10 steps, okay? And so that ultimately produces what is this product, what is called the pyruvate, okay? So this is what is mentioned here. The glucose which enters into the cell is metabolized to pyruvate through a series of 10 steps in this cytoplasm of the cell. Then this pyruvate is transported into mitochondria, and that only goes to produce what is called the ATP production. To produce, how many molecules of ATP will be produced from one glucose molecule?
36.
36 molecules of ATP if it is a aerobic metabolism. In the presence of or availability of oxygen, you will get 36 molecules of ATP from one glucose molecules produced by the conversion of pyruvate into the ATP molecules. Okay, but if the amount of glucose is too much, this pathway cannot handle the glucose load. So what will happen? It will get converted to what is called advanced glycation end products, AGE. This AGE stands for advanced glycation. Glycation means the glucose will go and get attached to other substances like protein, fat, cells, everywhere it will go and get attached, even to the hemoglobin. So what you call as a HbA1c is nothing but glucose
Glycos-
attached to your hemoglobin. Okay, so these are all the advanced glycogen end products. And then it also stimulates protein kinase C, which is an enzyme, and it will act on the NADPH oxidation. And it will, what is this ENOS stand for?
Endothelial
Endothelial
nitric
nitric
oxide
Endothelial
synthase.
nitric oxide synthase. Very good. Enzyme endothelial nitric oxide synthase. Okay. So these things are all stimulated, which will result in excessive oxidative production or the superoxides, which are going to cause oxidative stress. This is the basic mechanism of glucose toxicity. Excess of glucose acting on all these pathways stimulate what is called superoxide or oxidative stress, which will damage or affect the endothelium of the blood vessel. That is why you get micro macrovascular changes because of this particular effect of the excess glucose, which is called the glucotoxicity. So when the endothelium starts getting dysfunction, what are all the changes it produces? It can produce inflammation, it can produce platelet aggregation, it can produce leukocyte adhesion and migration, vascular wall remodeling, low density lipoprotein oxidation, vasoconstriction, which will all lead to early atherogenesis and arterial stiffness. So the basic culprit which causes all the complications in diabetes is the vascular modification that is happening because of the oxidative stress that is produced by the hyperglycemia, because the normal pathway gets oversaturated and it is not able to get utilized to produce the required energy. You have more than what you require, so that starts affecting the in various ways. Ultimately the endothelium gets affected. This is what is called the glucotoxicity. Please remember this picture very well so that you can understand how this is going to happen. Okay. Now, again describe the pathophysiology. In type 2, what happens is there is an increase in glucose production, or it can be impaired insulin secretion, or it can be inefficient glucose utilization, or it can be increased intake of glucose. So all these four things can result in hyperglycemia. You have excessive glucose production by counter-regulatory hormone levels being high, or your whatever insulin is being produced is not able to function properly, and glucose utilization is not happening because of that, and our patient may be eating excess of glucose more than what he can utilize. So that is the reason why we always say better to avoid sweets right from younger age group. Better to keep a control over your glucose intake so that you don't become a diabetic because of the excessive glucose load that you are taking, which cannot be metabolized properly. Now the next question is, all the organs, most of the organs in the body require insulin for glucose absorption and utilization. Which are the organs which do not require insulin for glucose absorption?
Brain and RBC.
Brain, GIT,
Brain.
and RBC.
Okay. Any more organs?
Red blood cells.
Which one?
GIT
So
also,
you
sir.
can remember this is the mnemonic for that, Brickle. Can you expand this mnemonic? B, your first answer, brain is B. R,
RBC.
ICALE,
I, intestine.
I, intestine. Very good. Intestinal lining cells. They don't require insulin. Very good. C,
Cornea.
cornea. Very good. Cornea does not require insulin. K, kidney. Nephrons do not require. L, liver does not require insulin for glucose uptake. Okay. So brain, RBCs, intestine, cornea, kidney, liver, and exercising skeletal muscle. That also does not require. When you are aggressively, actively exercising, those cells do not require insulin. That is the reason why we always insist that diabetic should do a lot of walking so that you can consume the glucose that you are taking. Okay, so remember this mnemonic: Brickle, brain, RBCs, intestine, cornea, kidney, liver, and exercising skeletal muscles do not require insulin for uptake of glucose and absorption and utilization. Now, how does hyperglycemia occur? What is the mechanism? Of course, we have seen that earlier. This picture will tell you that increased carbohydrate intake from as a source, then hepatic glucose production increase or decrease peripheral utilization or decrease insulin secretion. So this picture I just thought to introduce because you can easily remember how hyperglycemia results. So either excessive intake, excessive endogenous production, decreased uptake, or decreased secretion of insulin, all this will result in hyperglycemic state. The next question is, which glucose transporters are insulin independent? Now there are a family of glucose transporters which are called GLUT. GLU stands for glucose, T stands for transporter. So they are called GLUT. So there are 1, 2, 3, 4, 5, 6 like that, many numbered glucose transporters, of which transporters are not dependent on insulin. The earlier picture I showed you that the insulin should get attached to the receptor to stimulate the glucose transporter to open to allow the glucose to come into the cell. Which number glucose transporters are not dependent on insulin for allowing the glucose to go inside? And these are the ones which are present in the earlier slide I showed you, the organs which do not require insulin for uptake of glucose. They have this glucose transporters.
GLUT2.
GLUT2.
Yes, sir.
1 and 3. Okay, glucose transporter 1 and glucose transporter 3 are not insulin dependent, and these are the transporters which are present in the organs which I showed you in the earlier slide. That is the reason why they are able to take up or absorb glucose without the help of insulin. Now, another common question or the practical point which all of us should remember is, what is the correlation between capillary blood glucose, plasma glucose, and whole venous blood glucose? Nowadays, we check the glucose in the theater itself during surgery when we are dealing with a very severe diabetic and we are doing a major surgery. We can check the blood glucose by just pricking the finger and taking a small drop of blood and test it with the machine that is available with us for checking the blood sugar, which is called the capillary blood glucose. But when you go to a lab for checking your blood glucose, they draw a sample from your vein and then they give the reading. They don't take the capillary blood glucose. So will there be a variation in the value between this capillary blood glucose, or when you filter out the RBCs and take only the plasma, or when you check the sugar in the whole blood sample containing both RBCs and plasma? What will be the difference? It will be the same value or different value?
It will vary, sir.
It will vary. Very good. So what is the correlation? Supposing you check blood CBG in the theater, what will be the exact plasma glucose? Plasma glucose is supposed to be the ideal value of assessing the blood glucose. That means you have to centrifuge the blood, remove the RBCs and take the supernatant plasma and check the glucose in that. That is supposed to be the correct blood glucose value. But in CBG and whole blood, you will not be able to do that and the value will be different. Do you have any idea what is the relationship between these three values? Okay.
No, sir.
So CBG, if you test, it is 7% more than the plasma glucose. So I told you the ideal blood value of glucose is estimated from the plasma. So if you check the CBG, you must always add 7% more of the value to get the correct level of plasma glucose. That is the first correlation. And if you check it from the whole blood without centrifugation, it will be 15% less than plasma glucose. Can you tell me why it is 15% less?
Because of utilization.
The sample you have taken, will it be utilized? You are partly correct, but the answer is more, it should be more precise. Because more of the blood glucose where it can be, which cannot be estimated directly. It may be inside the RBC. Okay, so when you take the whole venous blood and try to estimate the glucose, 15% will be inside the RBCs, and that cannot be measured. So the whole blood value is 15% less than the plasma value, whereas CBG should be 7% more than the plasma value. This is the correlation which you have to remember so that you can make a correct assessment of the plasma glucose. Now, histology of islet of Langerhans cells and its secretion. This is one question which I thought we will be able to do. Sometimes the examiners may ask you about this. So the pancreatic cells, there are three types. Alpha cells which produce glucagon. There are beta cells which produce insulin and amylin. Then there are D cells which produce somatostatin, and there are F cells which produce pancreatic polypeptide. Okay, so these are all the secretions that happen from the pancreatic islet of Langerhans. And again, how insulin release occurs. So this is a very important knowledge that all of us should happen. So whenever the blood glucose level increases more than normal, or for utilization of your normal glucose intake, what is the mechanism by which insulin gets released from these pancreatic cells? Anybody can tell me what is the mechanism of insulin release from the islet of pancreas when we want to utilize the glucose that we have taken?
So whenever we eat, the glucose enters the pancreas through insulin independent GLUT1, and which triggers the insulin secretion by production of ATP.
That is a very, very simple way of telling it, but there are some more steps that you have to do. So as I told earlier, GLUT1 and GLUT3 transporters are insulin independent. So through this GLUT1, glucose has to enter the pancreatic cell also. So once the pancreatic cell glucose enters there, then these are the steps that are happening. See, the first step is glucose has to enter. Actually, it is put as GLUT2, which is present only here. So it is not GLUT1 which is happening, it is GLUT2 which is allowing the glucose to go in, and it gets utilized in the mitochondria of the pancreatic islet cells, and then it is metabolized. So there is an increase in the ATP, and the ratio between ADP and ATP is altered. This will stimulate what is called potassium. ATP dependent potassium channels will be stimulated. Okay, so what will happen? The potassium inside the cell will be driven out, and this will result in membrane depolarization, which will allow the voltage dependent calcium channels to open. Okay, so the utilization of glucose in the mitochondria, increasing ATP, opening the potassium channels, drying out the potassium, causing membrane depolarization, and allowing the voltage dependent calcium channels to open. So calcium enters the cell, and insulin is stored in vesicles, just like your acetylcholine being stored in the neuromuscular junction in vesicles. The natural mechanism of all the organs is more or less the same. So it is stored in vesicles, that will be exocytosed and it will be released inside. So that is the next step. Then what happens after a particular time, the calcium will be extruded and potassium will be coming back to restore the membrane repolarization, and this channel will be closed. So these are all the steps that are happening. This picture is very useful for you to remember how what are all the steps in the release of insulin that is happening in the pancreatic cells. So this is the mechanism which all of you have to remember. So the level of glucose, more glucose entry, more ATP, more release. So that is the way the insulin release occurs in the body. Okay, so this is a very important point, because this is the way you can stimulate your increased production of or release of insulin by your oral hypoglycemic agents. We will see that later how they are able to act to increase the level of insulin that is released in the body. So that they have to act only at this level. The oral hypoglycemic agents, most of them act at this level. The similar mechanism to increase the insulin release. Now, the next thing is all of us should know is how is insulin synthesized in the islet cells. What we earlier saw is how it is released, the mechanism, but what is the basic method of synthesis or manufacture of insulin? What is the first step or the basic unit of insulin before it becomes full-fledged active form?
Amino acids.
It is a chain of amino acids. How many chains are there? All of you should know. It's
51 amino acids.
Alpha, total 51, but it is separated into two chains.
Alpha is the
Alpha
chain,
chain and
third
beta
chain
chain.
and 21 beta.
peptides, sir.
So this is the step that you have to remember. See, the first step is called the pre-pro-insulin. It is not directly insulin that is produced in the body. It is produced as what is called pre-pro-insulin, where you can see that there is a chain. Three chains are there. Chain A is there, chain B, beta chain is there, and there is a chain C which are produced. And this is the signal sequence from which it has to be cleaved and then further converted into active form. So this is the basic unit of insulin, which is called pre-pro-insulin. These are called the disulfide bonds between the beta and alpha chains. So finally, these two chains are only going to be there as an active form. What is given here is in the light green color and blue, all will be cleaved out or cut off and removed. So the next step is what will happen. There is a signal sequence that is stimulated. So this pre-pro-insulin becomes what is called pro-insulin. In pro-insulin also, the alpha chain and beta chain is connected by what is called the C chain, or this is called the C peptide also. Some books say it is C peptide or C chain. And then finally this C chain will be removed and you will have only the alpha chain and the beta chain connected with the disulfide bonds. This is the final formation of insulin. So from pre-pro-insulin to pro-insulin and insulin. Now you can see in this picture the chain C has been removed. What is the importance of this chain C or the so-called C peptide? Why should we know about this steps in the synthesis of insulin? How can you differentiate between type 1 and type 2 diabetes? Supposing a patient who is only 20 years old, he has a blood sugar of 300, and you suspect type 1 diabetes in that patient because the patient is very young. How will you establish your diagnosis? Which diagnostic tool will help you to establish that the patient is suffering from type 1 diabetes?
Abnormal
analysis.
peptides.
What is the definition of type 1 diabetes? Is there any production of insulin in that patient?
No, sir.
No. Type 1 diabetes means there is complete or
Autoimmune
deficient
destruction of
insulin
beta
production.
cells.
So if you measure the C-peptide level in the blood, if it is totally low or absent, then the patient is a type 1 diabetic, because these are the steps through which insulin has to go through to become active form. So in a type 2 diabetes, there is a production of insulin. So C-peptide level will be there because it is cleaved. But the insulin that is finally produced is not able to act because of antibody reaction, or the receptor not responding, or the molecule is slightly defective, the amino acid chains are not properly made. So that is the reason why I told you about why insulin resistance occurs. And this C-peptide is a very, very important diagnostic tool to differentiate between type 1 and type 2, because in type 1, there is total lack of insulin production. So there is no pre-proinsulin, there is no proinsulin, and there is no cleaving of peptide C-peptide or this chain C. And so if you, there are tests to measure the C-peptide level in the body, in the blood. So if you are not having any C-peptide in the blood, that means the patient is a type 1 diabetic, because he is not producing any insulin at all. So that is the reason why we should have this knowledge. And another reason why we should know the synthesis is these amino acids chain, which are called A chain and B chain. By modifying the sequence of amino acids, we are now able to produce clinically usable insulins, which are very, very similar to this insulin that is being produced in the body. What is the name for that insulin that we are now able to produce and get a very, very fast action? In case of hyperglycemia, you want to reduce the blood glucose quickly before surgery. What is the modern latest available insulin preparations which will be able?
Actrapid.
Actrapid was the regular insulin that was available earlier. That is much more faster than that. Have you heard of insulin Lispro?
Yes, sir.
Which is called
Yeah.
insulin analog. Nowadays we have drugs which are called insulin analogs, which can be almost similar to the insulin that we have here, and they can reduce the blood glucose within 10 to 15 minutes. Even actrapid will take about 25 to 30 minutes for its onset of action. But the insulin analogs which we have, the example is insulin Lispro, which can reduce the blood sugar within 10 to 15 minutes when it is given intravenously. Okay. So that is the reason why we should be knowing about this, how the synthesis happen. Two reasons: one, to identify between type 1 and type 2. Two is to know about the recent availability of insulin analogs, which are nothing but the slight modification in the amino acid sequence of the alpha and beta chain. Okay, is it clear?
Yes, sir.
Okay. Now describe the structure activity relationship of insulin. So how do the insulin work? So that this picture will tell you, as you rightly said, there are 51 amino acids. Alpha chain has got only 21 of them, and beta chain has got 30 of them. So total 30 plus 21 is 51 amino acid sequence, and they are connected by these disulfide bonds in these two levels, between the 7th amino acid in the A chain and the 7th amino acid in the B chain. Is the one first disulfide connection. Here you can see these two, and between the 20th amino acid and the 19th amino acid in the second sequence is the disulfide bond, and the third one is within the A chain itself, between the 6th and the 11th amino acid. So there are 3 disulfide bonds present in the configuration of the insulin, and when the insulin comes, earlier we saw it comes and occupies the receptor, just like imagine your neuromuscular junction, where you have the acetylcholine receptors with 2 alpha, beta, delta, gamma, like that. Here also the receptor has got 2 alpha domains where the insulin has to come and attach itself. Then it will stimulate the internal sequence. So there is an extension of this receptor intracellularly into the cytoplasm, and this will a model of insulin receptor and mediation of the metabolic and cellular response. So there is a stimulation of what is called tyrosine residue, and that will go on to produce all the changes, and ultimately it will open the glucose transporter glut to allow the glucose. So insulin does not directly cause the entry of glucose. It has to stimulate via second messenger system to open up the glucose transporters, and through that only glucose can enter, and then it can produce all the changes. So there is a series of reactions going on and producing all these changes inside the body, and then finally these receptors are degraded and then recycled to utilize that. So grossly, instead of remembering all the steps, what you can remember is insulin gets attached at the extracellular domain of the receptor, causing a series of intracellular signaling, resulting in the opening of the glucose transporters to allow the glucose inside the cell. So if you remember that much, that is enough. Okay, so that is the mechanism of structure activity relationship of insulin. Now, what is the pattern of insulin release in our body? This knowledge is very, very important for all of us. Don't think that I am trying to take a class as of we are diabetologists, but this knowledge is very, very important, because based on this only we have to know what type of insulin we have to select for patient treatment. So what is the pattern of insulin release in the body? Endogenous insulin, does it have does it get released only when you take a food containing glucose, or is there a constant production?
There will be a baseline constant production and increase in the production after every meal.
Every meal, okay. So this is called the basal release and the bolus release. So remember these two terminologies: basal release of insulin and a bolus release of insulin. Whenever you take an extra load of glucose, you require more insulin to utilize that. That is called bolus insulin. But constantly, for our basic metabolic needs, we need insulin to utilize the glucose for our day, even when you are resting. So whenever you cannot be without energy, even when you are sleeping. So for that you require insulin to utilize the glucose, and that is called the basal production. So this is called the biphasic pattern of release: pulsatile release or short-term blood glucose control after a meal, or protracted release or long-term insulin release for cell growth, cell division, and protein synthesis. So if you see this, these are the basal release picture, and whenever your blood glucose level goes up, there is a spike in the release, then it comes back to the basal level. Okay, so this is picture will tell you. And what is the mechanism of action? Again, we have seen that already. In a normal insulin, it has to come and occupy the receptor. Then the blood transport, when the insulin is away and it is not occupied the receptor, the glucose entry port or the transporter is closed place, and when the insulin occupies the receptor, it opens the glucose channel, or the glut is opened, and then the insulin enters here. So this picture again I have put it for it to make it simple and easy to remember. What is the concept of mixed insulins? So why we talked about this basal and the bolus release or biphasic release is, we have in the market a lot of insulins which are long acting and short acting, or intermediate acting and long acting. So majority of the diabetologists, would have prescribed the patient to have a mixture of this 70-30 or 75-25. So many combinations are available, which are long-term and short-term or quickly acting insulins. So this is to match the basal and bolus insulin, mimicking the nature. That is how the concept is there. So you have a constant, red is the basal insulin, you can see here. Then the blue is the bolus insulin, and for breakfast, lunch, dinner, and at bedtime. So these are the 4 times where you need the variations to happen. So to match that normal secretion, we have the concept of mixed insulins, which can act as the long acting ones will produce the basal production or will match the basal production, and the short acting ones will take care of the amount that is required whenever glucose intake is increased. Okay, so that is the concept of mixed insulin. Now, what is the mechanism of insulin resistance? Again, same thing. What we have seen is it works like this principle, what we showed you in the earlier picture, and this is the normal metabolism. Insulin occupies, and then the normal intracellular glucose is able to go. Whereas in insulin resistance, it is not able to occupy the receptor, or the receptor is not, the insulin molecule structure is not there. So unless it occupies the receptor, it will not allow the blood or the glucose transporters to open. So the receptor will not, the transporter will not allow the glucose to come in. So in this you can see plenty of glucose molecules entering the cell, whereas in the insulin resistant patient where the insulin is not able to occupy the receptor, very few molecules are inside. So it is not able to go inside. Just again another diagrammatic way of describing. Now what is polyol pathway and advanced glycation end product production, which we saw in the earlier picture, which is the glucotoxicity. So whenever the glucose is entering there, there is an enzyme called aldose reductase, which will convert it into what is called sorbitol, and this sorbitol will go to produce fructose. This will happen to a very small extent in normal glucose level, but whenever you have a excess glucose, hyperglycemia, then this pathway will happen. This is called the polyol pathway, where glucose is converted to sorbitol and then to fructose, which can be eliminated in the urine to some extent. Okay? So this enzyme that is required for that is what is called sorbitol dehydrogenase. And this advanced glycation end products, which is also another metabolic change that we are having, is glucose may get converted to sorbitol, fructose, fructose 3, and then go on to form what is called oxaldehydes, and then lipid peroxidation and shift base and amide product. All these things are nothing but attachment of glucose to other molecules that are there in the body, and amino acid also combines with that, and over the period of time this advanced glycation products will cause inflammation of the endothelium, which we saw in the very first picture. So if you remember that, it is more than enough. So all these pathways which are going to cause ultimately a insult or injury to the endothelium of the vasculature, that is going to cause all the complications, both micro and macrovascular complications. So that is the idea of this slide, again to insist and make you learn that this is the mechanism how the diabetic complications happens. Of course, again, this is another method of glucose toxicity mechanism, PKC, that is protein kinase C activation and superoxide production, and hexosamine pathway. These are all the other mechanisms by which the glucotoxicity happens, which we saw in that. So these are the 4 pathways again, which cause the endothelial damage in patients with hyperglycemia. That is the reason why the physicians always say keep your blood sugar under control, because to prevent the glucotoxicity that will be happening if the persistent elevated blood sugar levels are persistently elevated. So these are the 4 pathways: polyol pathway, hexosamine pathway, DAG pathway, AGE pathway are the methods by which the damage occurs. Now, whenever your patient comes to you with history of long-standing diabetes, you must ask them whether they have had any incidents of diabetic ketoacidosis at any time. Now, this diabetic ketoacidosis is a very common question in the examination, both in theory as well as in your Viva examination. The examiners will ask you what is the danger of a patient going into DKA and how do you manage that. This is a very important topic, both from your exam point of view as well as in future practice. You must know if you become an intensivist, you may land up with a patient, you may get a patient landing up with diabetic ketoacidosis in your intensive care. So, what is your idea about the DKA? Then, how do you define diabetic ketoacidosis? Or what are all the features of diabetic ketoacidosis?
When the blood glucose level more than 250 milligram per deciliter, when the pH of the patient is less than 7.35,
Very
and the
good.
presence of ketones in the blood or urine.
Very good. Then, any more? One more added point.
Bicarb level less than or equal to 18, sir.
That is metabolic acidosis.
And serum
Anion gap
osmolality
should
less
be.
than.
You must also have check for the anion gap is very, very important. You must do an ABG and find out the anion gap, which will be invariably increased. Okay, so it's a serious complication of diabetes, which is common in type 1 patients. Very rarely you can get it in type 2 also, but it is much more commoner in type 1 patients. So what causes DKA? What are all the causes which can trigger the patient to develop this diabetic ketoacidosis?
Infection.
Very good, correct. Any stress can cause missing of insulin dosage in the patient who is taking chronic insulin. If they skip a dosage, okay, so caused by infection, missing insulin dose, steroids, or stroke. These are all the conditions and causes which can result in the production of DKA. What are the clinical features? How will a patient with DKA present to you?
So usually they'll present with acidotic breathing.
Very good. Then is that the only thing?
Nausea,
Blood sugar levels will be high.
Initially, they may have nausea, vomiting. Very good history of nausea, vomiting. Altered sensorium, tachypnea, with
increased blood glucose
odor in the smell, in the breath. Okay, so vomiting, abdominal pain, excessive diuresis, fruity odor in expired breath, gasping type of breathing, altered sensorium, and weakness due to dehydration. Okay, these are all the clinical features of DKA. Now, how is it diagnosed? When a patient presents with the above clinical features and you suspect DKA in that patient, how will you diagnose the condition? What are all the investigations you require?
We have to look for serum glucose, urine ketones.
Diagnosed by presence of severe hyperglycemia, ketones in blood and urine. Normal value of blood is only less than 1 millimole. Okay, so it may go to 3 or 4 millimoles also sometimes in DKA. So always remember that normal blood ketone value is less than 1 millimole, 0.1 to 1 millimole. What is the use of this ketone in normal blood also?
For energy production when?
So it is the primary source of energy production.
When glucose is secreted, it acts as another source of energy, sir.
It is excellent. It is also another source of energy, especially for which cells?
Brain cells.
Brain cells. Very good. It is another source of energy for brain cells. That is why when you are starving, it is the ketone which gives the energy for the brain. If you are held up in the theater, you had your breakfast at 6 o'clock. For MEAD students, earlier it used to start at 6 a.m. So you have a breakfast at 5:45 and you get caught in a liver transplant until 7 in the evening, you have not had anything to eat. Then it is the ketone which supplies the glucose and the necessary energy for your brain cells. Okay. So there is a normal role for ketone in the blood also, but when it becomes excessive, it becomes a depressant, it becomes a toxin. That is what you have to understand. And also there is an anion gap acidosis. That is a very important diagnostic clue. Not only severe hyperglycemia and ketones present, but we must also have an anion gap metabolic acidosis. Now, how do you treat this condition? This is a very common question that examiners are fond of asking, and this is the answer expected in your theory paper also. There's a note question on DKA. How do you treat patients with diagnosed with diabetic ketoacidosis?
We have to hydrate the patient,
Very
glycemic
good.
control.
Very good. So the DKA itself is a mnemonic for that. D stands for dehydration. Patient will be very, very severely dehydrated. So fluid resuscitation tops the list, number one. Second, potassium. K stands for potassium. So patient who will be initially hyperkalemic will start becoming hypokalemic once you start fluid resuscitation. And third is control of acidosis. So these are the three things that you have to take care. So treatment is by time-bound correction. So whenever you start treating a DKA patient, you must note down the time of starting the treatment, because it is a time-bound treatment. Every 1 hour you have to check the parameters and see whether the status is getting corrected or not. So that is why it is called the time-bound correction. So start noting the time, and every 1 hour repeat the blood sugar and potassium values and the ABG, so that you can know whether you are progressing in the right direction or not. So first thing is to correct the dehydration with saline during the first hour, along with insulin to reduce the blood sugar. Then correction of hypokalemia from second hour when blood sugar reduces, and then automatically the acidosis will get slowly corrected. What are the differential diagnoses of DKA? Very common differential diagnosis.
Hyperosmolar hyperglycemia.
HSS, very good. Hyperosmolar hyperglycemic state, or HHS. Then other conditions are alcoholic ketoacidosis, ethylene glycol intoxication, lactic acidosis, myocardial infarction, pancreatitis, starvation ketosis, methanol intoxication, paraldehyde ingestion, rhabdomyolysis, salicylate intoxication, uremia. All these things are differential diagnosis for DKA. And how to differentiate between DKA and hyperosmolar hyperglycemic state?
So the blood glucose level will be very high. It is more than 350 milligram per deciliter.
More than that?
More than 600.
Yes.
Pathognomonic difference.
Yes, sir.
And serum osmolality.
And the serum osmolality will be more than 600 milliosmoles.
Yes. So it is a hyperosmolar condition. So plasma glucose, if you compare mild DKA, moderate DKA, severe DKA, and the hyperosmolar hyperglycemic state, plasma glucose will be alarmingly very, very high in the hyperosmolar hyperglycemic state. And pH will be more or less normal, despite the fact that sugar is so high. Hyperosmolar state, the pH is always more than 7.30. Acidosis will not be very dominant. And bicarbonate may be more than 15. Whereas in severe DKA, it will always be very, very low. And urine ketones are very, very negligible. That is a very important differentiating point between DKA and HSS is the amount of both urine and serum ketones is very, very small or negligible, but the osmolarity is severely high. That is why it is called hyperosmolar So what is the normal osmolality of the blood?
295 milliohms.
280 to 290. Very good. So that is more than 320, and anion gap is also not very high in hyperosmolar hyperglycemic state, and patient will be in stupor or coma, which is, whereas here it will be alert, drowsy, and then gradually only. If a patient with DKA is in coma, that means he is in a very serious state. Whereas hyperosmolar conditions, patients come in a stupor state. But these are all the differentiating points. Severe hyperosmolarity, very negligible ketones, and pH always more than 7.3, and blood sugars are alarmingly very, very high. So these are the important differentiating points. So what are the key features of DKA? These are the blood sugar between 300 to 500, ketones positive, sodium will be very low, anion gap will be very high, pH always less than 0.73, total carbon dioxide is decreased. Why?
Compensation, hyperventilation.
They will be hyperventilating. Correct the acidosis, they will be hyperventilating. So carbon dioxide will be washed out, and they will have hyperkalemia because of the acidosis, and bicarbonate also will be low. So these are the 8 features which you have to remember for diabetic ketoacidosis. Blood sugar very high, ketone positive, sodium low, potassium high, anion gap increase, bicarbonate low, and pH is low and carbon dioxide is low. So this picture will have to remember and write in your exam as the key features of DKA. Now compare the features of DKA and hyperosmolar. Who are more prone for this? Which again we have seen earlier. Who are all the patients more prone for these conditions?
Type 1 diabetes were on
DKA. So DKA triad is hyperglycemia, metabolic acidosis, ketonemia, and it is more common in type 1 diabetes mellitus, but can occur in type 2 also. Whereas the hyperosmolar hyperglycemic triad is severe hyperglycemia, elevated serum osmolality, they are severely dehydrated, and it can occur in type 2, often presenting following long or protracted courses of illness. So it is more common in only type 2, it never occurs in type 1. And describe the pathogenesis of DKA and hyper comparison. What is the pathogenesis? I'll just show you this picture. So any stress infection or insufficient insulin, skipping a dose, can lead to this condition. So what happens when there is an absolute insulin deficiency as occurring in type 1 diabetic patient? There is an increase in lipolysis, and that leads to free fatty acids going to the liver, and from that only by beta oxidation you get this ketones. What are the ketone bodies?
Acetone, acetoacetate, and beta hydroxybutyrate.
Hydroxybutyric acid. Excellent. Very good. These are the 3 ketone bodies which are produced from the free fatty acid. So that decreases the alkali reserve. Bicarb goes down. So this results in what is called ketoacidosis. Okay. And this free fatty acids also leads to triacylglycerol formation, and hyperlipidemia also occurs. And from here, the counter-regulatory hormones are increased, and glucose utilization is decreased, gluconeogenesis occurs, glycogenolysis occurs, all these things produce hyperglycemia. And then osmotic diuresis occurs because of the increased glucose gets filtered in the urine and acts as an osmotic diuretic. That is the cause of dehydration. So loss of water and electrolytes, severe dehydration occurs, and there is, if the dehydration is not corrected in time, patient goes for renal failure. And decreased fluid causes the osmolarity, increase in osmolarity also. And when there is a relative deficiency, there is a very minimal or absent ketogenesis. So this is what is happening in these patients. So type 2, you don't get that much of ketone production like in type 1 diabetes. So this is the mechanism of HSS and DKA. So DKA is characterized by ketoacidosis and dehydration and excessive glucose. Whereas hyperosmolar hyperglycemia is excessive glucose, increased osmolality, and very minimal ketogenesis that is happening. So that is the difference you have to remember. Now, what are the 5 I's for DKA? What are the 5 conditions which result in DKA? Are insulin deficiency, new onset type 1 diabetes, mellitus or failure to take insulin, infection like pneumonia, UTI or cellulitis, especially patients coming with diabetic ulcer foot, they are more prone for DKA, and inflammation like pancreatitis or intoxication with alcohol or drugs, and iatrogenic, to give too much of glucocorticoids, thiazides or symptomimetics and antipsychotics. All these drugs also can lead to DKA. So remember these 5 conditions which can lead to DKA, and other conditions rarely can be anterior myocardial infarction or cerebrovascular accident. These also can lead to. So in any diabetic patient, if they suffer an angina and have AMI or stroke, you have to watch out for DKA in those patients. Now there is a new terminology where patients have normal glucose but they have elevated ketone levels, and they are called euglycemic diabetic ketoacidotic patients. So what is the which patients this condition is common? This condition has been identified recently after the introduction of a particular drug for control of diabetic state. That is the clue for this. Metformin. Metformin produces lactic acidosis. That has been there for time immemorial when metformin came into usage. A drug which is now commonly prescribed by diabetologists for very resistant diabetic patients. Original description of DKA were all associated with severe hyperglycemia with blood sugar levels above 350 milligrams. But of late, patients exhibit ketoacidosis even with blood sugars less than 200 milligrams. This is termed as euglycemic or normoglycemic DKA. This condition has been reported in patients with severe sepsis, pregnancy, and patients treated with this particular drug, SGLT2 inhibitors. Okay?
Yes.
Serum glucose, sodium glucose transporter 2 inhibitor drugs, which are now commonly prescribed by many diabetologists for patients with diabetes. So gone are the days when they were depending on sulfonylureas mostly and metformin. Nowadays, the concept of treating diabetic patients starts with, what is the current guideline for oral hypoglycemic drug treatment for insulin? What is the first and preferred drug? Earlier it was metformin, then you used to add sulfonylurea like Amaryl or limepiride, glypride, all these things. But now the preferred combination is dipeptidyl peptidase 4 inhibitor with metformin, Janumet or Januvia. Okay, so the first line of treatment advocated is dipeptidyl peptidase 4 inhibitor with or without metformin is the first line of drug. The second line that nowadays they prefer is going for this SGLT2 drug, sodium glucose cotransporter 2 inhibitors. Okay, so that is the reason why this drug has become more popular. So treatment is similar to hyperglycemic DKA. Even if the patient develops euglycemic diabetic ketoacidosis, they may have hyperglycemia with dehydration. So you have to treat them like DKA with fluids but insulin should be titrated carefully because they will not have too much of rise in blood sugar level. So if you give insulin like what you give for DKA, you may land up with hypoglycemia, which is much more dangerous. So restricted use of insulin and early correction of dehydration are the goals in the treatment of euglycemic diabetic ketoacidosis. Now, what are the precipitating factors, symptoms, signs, and diagnostic criteria of euglycemic DKA? These are all the things. So, SGLT2 inhibitor induced euglycemic diabetic ketoacidosis. Symptoms are asthenia or weakness, tiredness, fatigue because of loss of fluid, excessive thirst and urination as a compensatory mechanism. They may just come with abdominal pain, which may mimic an acute abdominal emergency, vomiting again, compounding or leading to dehydration and hypotension, and they may also have altered mental status. Precipitating factors, if a patient is already on this drug, which can precipitate the euglycemic decay or acute illness like infection, CVA, pulmonary embolism or MI, dietary changes, not taking enough glucose, too much restriction on glucose intake and taking more of protein and fat, preoperative or postoperative fasting or low carbohydrate diet, underlying malignancy or other drug abuse in pregnancy are all precipitating factors. And for diagnosis, it is always low, not alarmingly high glucose values, less than 300. Metabolic acidosis with like high anion gap like DKA, and ketonemia or ketonuria is also present. So this is a slight modification, except for the low blood sugar values, all of the features of DKA are there. Now, what is the mechanism by which this euglycemic DKA is caused by these drugs, which are in common use now, sodium glucose transporter 2 inhibitors? This is the mechanism. So if you see SGLT2 inhibitors, they act mainly on the kidney and they prevent reabsorption of glucose. So excess blood glucose, when it gets filtered in the proximal convoluted tubule, in normal kidney, 95% of the glucose will be reabsorbed if it is within the threshold. Whereas the SGLT2 inhibitors act on the nephrons and prevent the reabsorption. So it results in what is called glycosuria. Large amounts of glucose are getting excreted in the urine. And along with that, sodium also, because it's a sodium glucose co-transporter. So when glucose is not absorbed, sodium cannot also be absorbed. So patient loses a lot of sodium and increased ketone body reabsorption happens. And this results in action on the pancreas, causes increased glucagon production, increased insulin secretion, and acts on the adipose tissues to produce lipolysis. This is the way ketogenesis happens, beta oxidation of free fatty acids. So plasma ketone bodies increase, and this results in, because glucose is lost in the urine, blood glucose levels do not rise. So patient has a euglycemic decay. So that's the mechanism of this particular complication. Now some confusion may exist in HbA1c. Now what is this HbA1c? What is the expansion? How do you call it? What is HbA1c? What is its importance?
Glycosylated hemoglobin.
Glycosylated or glycated hemoglobin, very good. So glycation of proteins is a frequent occurrence, but in the case of hemoglobin, by a non-enzymatic condensation reaction occurs between glucose and the N end of the beta chain. Okay, so beta chain, the glucose gets attached to the nitrogen end of the beta chain, which we saw in the earlier picture, how it is the signaling system occurs at the end of the beta chain. So the glucose gets attached there. Now, what is diagnostic use of HbA1c? How is it important to
It is proportional to the
depends.
plasma glucose concentration during the 3 months, sir.
3 months, excellent. So it's a diagnostic for if it is less than 5.7, it is normal. 5.7 to 6.4, it's pre-diabetic, and more than 6.4, it's a diabetic. So that is how the values we take into consideration. Now, what is the correlation between HbA1c and average glucose level? Supposing you get a HbA1c as 6.5 for a patient, what will be his average blood glucose? How do you know the average value of blood glucose? To say, or a patient having a blood HbA1c of 8, and if he asks you what was my average during the last 3 months, doctor, if he asks you the question, how will you calculate and tell him? Normally, this chart is there, which will tell you what is the HbA1c according to the value. For a value of 6, the average is about 126 milligrams or 7 millimoles. Okay. For a value of 7 HbA1c, it is about 154. This is the mean plasma glucose in milligrams and millimole. Bottom line is millimole and top is milligram. So 8 means 183, and 9 means 212, 10 means 240, 7 269, and 12 298. So as the number increases, the average plasma glucose also goes on increasing. But there is a formula to calculate. This is the formula. To convert HbA1c to estimated average glucose, you have to multiply the HbA1c with 28.7, and from that you subtract 46.7, then you will get this value. So the formula to, so if your patient asks you what is the my average blood glucose, you can easily do this calculation. If you have a computer, smartphone, you can go to the calculator, just multiply the HbA1c with 28.7 and then subtract 46.7, then you get the average blood glucose level. And this is because for the last 3 months. Why it is for the 3 months? Why? How does it give the average for the last 3 months?
The lifespan of RBC is 120 days.
So it gets attached to the RBC. So the lifespan of RBC is 120 days. So that is the reason why you get about last 3 months of value. What is hypoglycemia awareness? Unawareness rather. This is the terminology which you have to know, especially in patients who are coming to you with a history of diabetes. You must always ask them whether they have undergone any episodes of hypoglycemia, because we always say the dictum in treatment of diabetic patient is err on the hyperglycemic side rather than on the hypoglycemic side. So better to have a slightly higher blood sugar rather than go for low blood sugar value. So hypoglycemic unawareness is the repetitive episodes of hypoglycemia if the patient has been experiencing, especially with the drugs like sulfonylurea. They are notorious for producing hypoglycemia in the initial stages of treatment. So if you prescribe oral hypoglycemic agents to any patient, you must always tell them what will be the features or symptoms of low sugar or hypoglycemia, and ask them to keep some sugar preparation ready always in the initial stages so that they can immediately follow that to correct their hypoglycemic state. So repetitive episodes of hypoglycemia, especially at night, can result in this condition in which patient does not respond with appropriate autonomic warning symptoms before neuroglycopenia ensues. That is, hypoglycemia causes its very severe complications by low sugar in the nervous system. So the brain gets affected. And so that is called the neuroglycopenia. So how you diagnose this condition is plasma glucose level you have to estimate, and that will be less than 50 milligram in deciliter, which is indicative of this condition. So in always when you suspect hypoglycemia, it is better to do a CBG and find out what is the level. Even if you can't do a blood sampling and estimate the plasma glucose, CBG itself is good enough to find out whether the patient is hypoglycemic or not. Now, normal hypoglycemia, what the symptoms will be, all of you know, would be, it can be divided into adrenergic response like sweating, tachycardia, palpitations, restlessness, or pallor. And the other system is neuroglycopenia, like fatigue, confusion, headache, somnolence, convulsions, or coma. So you can classify the symptoms of hypoglycemia into adrenergic and neuroglycopenic, and these are all the features that will happen. Now, how do you treat hypoglycemia? This is a very, very basic fundamental knowledge every medical graduate should have. So how do you treat the hypoglycemia?
First is we can give sugar, sir. Then IV
Intravenous,
glucose.
50%, 50 ml of glucose.
50%, 50 ml glucose. Okay.
Or
So you can divide this treatment into conscious and unconscious patient. That is a very, very important differentiation. In a conscious patient, you can give anything orally. But patient, if he comes unconscious, majority of times in the ER, you are brought a patient who is not responding, who is unconscious. But he will be having a tachycardia, a bounding pulse, hypertension, sweating, diaphoresis, and he will not be responding. So only when you push the glucose inside intravenously, he will start waking up slowly. Okay. So first thing is to differentiate whether the patient is conscious or not. So in a conscious patient, you can give oral glucose tubes, tablets, or even chocolates, soft drinks, any of the things, because patient can swallow that, and that will itself will be a remedy for that. But if the patient is unconscious, you have to give glucose IV at the dose of 0.5 gram per kg. Okay, not just blindly 50%, 50 ml. That was the older teaching. But you can calculate 0.5 gram per kg, or any other alternate for that. If glucose is not
glucagon.
Glucagon. How much dose?
0.5 to 1 milligram glucagon.
Very good.
Intramuscular.
You can give it in by any route. IV, IM, SC is also another option for that. Okay. So this is the treatment of hyperglycemia, which all of us should know to do that, because it's a life-saving treatment. Patients who come with hypoglycemia, if they are not treated in time, that can result in severe mortality. So you must know. And what are all the various different insulin preparations you know of? This is another common question that the examiners want to ask you. And also from practice point of view, you should know what are all the various insulin preparations that are available.
Nasal.
Nasal, straight away, most recent. Commonly used insulins. Okay, so this is the important thing. You can calculate them based on the duration of action: short acting, long acting, and intermediate acting. That is how they are classified. And this aspart, lispro, these two are what I told you as insulin analogs. They are very, very short acting and very fast acting also. Onset is less than 0.25 minutes. And their peak action comes in within half an hour to 1.5 hours. And their effective duration is just 2 to 4 hours. Then there is a glulisin, which is also similar. That's lispro. This is the regular insulin that has been introduced long back, which is called Actrapid in the market, which we are still using to reduce. But much more recent than this regular insulin is these three: aspart and glucagon and lispro. This is where I told you a small modification in the amino acid sequence has been successful in producing these insulins, which are very, very similar to the normal endogenous insulin. How they are able to act so fast? What is the reason for their action becoming so fast compared to the other insulins?
Due to
Insulin is
Short
also
peptide
stored
chains.
as a polymer. Okay, the insulin molecule containing an alpha and beta chain, it is a monomer. One chain alpha, one beta chain containing insulin is called a monomer insulin. And that monomer insulin only can act much more faster. But when it is stored in the body, it can be stored as a polymer also. That is just like your glucose getting converted to glycogen. Many insulin molecules can be clubbed together and stored as a polymer. And that has to be broken down to produce the monomer and release a single unit for its action. Whereas in this aspart, glucosamine and lispro, they are all available as a monomer, just like the ready-made acting insulin which is available in the body. And that is the reason why their onset of action is much more faster and shorter also. They are immediately broken down and their duration of. So this helps in our quick control of hyperglycemic state. So for example, if you have a patient waiting for a major surgery, and you do the blood sugar before you shift the patient to theatre, and it is 250. By giving a small dose of this, you can reduce the blood sugar within 15 minutes and bring it down to 150 and take him up safely for surgery. Whereas in the earlier years, you have to wait for half an hour, 45 minutes, 1 hour to get the blood sugar down. So the advantage of these three insulins, which are monomers, is that you can reduce the insulin much faster and get it bring it down below 200, which is the goal that we normally aim for. So this is the short-acting insulin list that you have. Then you have long-acting, which can supply insulin level required for the entire day. So they are called detrimer, glargine, and NPH, and their onset of action itself is very long. When you administer them as a subcutaneous injection, it takes at least 1 hour or 2 hours for the onset or beginning of the action, or sometimes even up to 4 hours, and they act for 12 to 24 hours effective for. So they are all given as a single dose per day, and they are able to do that. And these insulin combinations, which are all, as I told you earlier, to mimic the natural secretion of insulin like basal and bolus, biphasic method of insulin release, to have all the combinations with a long-acting as well as a short-acting insulin, protamine, lispro, or aspart, and NPH, which is the common regular PH insulin and regular insulin combination. This is the older combination. These are all new combinations which are available. So they have this dual effect of supplying both the dole as well as the bolus injection requirements. Now the next important thing is, whenever you get a patient with history of diabetes, you must test them for their autonomic function integrity. It's a very important, especially if they give a long-standing history of diabetic mellitus. You must test them for the autonomic integrity or the presence of diabetic autonomic neuropathy should be ruled out. So for that, you must do the testing. And this is a question that is asked in your theory paper also, as how do you test for the integrity, or how do you test for the presence of diabetic autonomic neuropathy. And it is important from practical point of view also, because patients who have already suffering from established diabetic autonomic neuropathy, they are likely to go in for severe hemodynamic instability, both during general anesthesia as well as regional anesthesia. So you have to establish or rule out the presence of diabetic autonomic neuropathy, especially on the cardiovascular system. So how do you test for the parasympathetic function? Because autonomic neuropathy can affect both the sympathetic as well as the parasympathetic component of the autonomic nervous system. So we always try to test for the two systems individually, parasympathetic function as well as sympathetic function. So how do you test for the parasympathetic function? It is by the heart rate variability response during deep breathing, where you can ask the patient to breathe, take deep breaths for several times, Then respiratory sinus arrhythmia is a normal phenomenon due to vehicle input on the sinus node during expiration, causing cardiac deceleration. So normally during cardiac deceleration, there is a decreasing cardiac rate. Whereas the test is done by asking the patient to lie quietly and breathe deeply at the rate of 6 breaths per minute. That is the number of times you should breathe. And while the heart monitor records the difference between the maximum and minimum heart rate. So the normal variability will be more than 15 beats per minute, whereas in abnormal it will be less than 10 beats per minute. That is the first test. Then you can do this during standing. This test evaluates the cardiovascular response elicited by the change from horizontal to vertical position, especially orthostatic hypotension, as well as you can also record the heart rate variability. In healthy subjects, when the patient is coming to standing position from lying position, there is a rapid increase in heart rate that is maximal at approximately the 15th beat, and the relative bradycardia that is maximal at approximately 30th beat after standing. So up to 15, there will be slight increase in the heart rate. From 30th, it will be reduction. So the patient is connected to ECG monitor while lying down, and then he should be made to stand up till full upright position. Then you record the ECG tracings used to determine the 30 to 15 ratio, calculated as the ratio of the longest RR interval found at about the 30th beat to the shortest RR interval found at the 15th beat. This is what is called the 30 to 15 ratio in standing position. These two tests help you to find out the integrity of the parasympathetic system. And this also is another picture of how to find out these variations. And in cardiac autonomic neuropathy occurring in diabetic patients, this picture tells you you have a control by both sympathetic and parasympathetic on the heart in the normal heart rate. Whereas if the parasympathetic is affected, there is a resting tachycardia because sympathetic is still intact and it is controlling the heartbeat. So there is a decrease in heart rate variability and exercise intolerance, and fatal arrhythmias happen. But if both parasympathetic and sympathetic are affected, then patient develops what is called orthostatic hypotension. So if the patient does not develop orthostatic hypotension, that means sympathetic is intact, only the parasympathetic is affected. But if he develops orthostatic hypotension or silent MI or supine hypertension, then from the clinical examination itself, you can find out that both sympathetic and parasympathetic are affected. So this is a very easy method of diagnosing this particular phenomenon. Then the question of how to use the insulin for glucose control. Normal glucose, you have to use only regular insulin or Lispro for quick control of your blood sugar. So the other common question that the examiners will ask you is, how do you use the insulin for quick control? Is by what is called the sliding scale regimen. There, if your blood sugar is between 150 to 200, 2 units can be given. 200 to 250, like that, you go on increasing, or more than 350, you can give 10 units subcutaneous. But this has been the method used for a long time, but now because of the availability of other methods, we can use this as an IV method also. In IV sliding scale, this is subcutaneous regimen. Whereas in IV sliding scale, you have to use 50 units of soluble insulin, that is regular insulin, in 50 ml of normal saline. So you mix 50 units of atropine into 50 ml of normal saline, and you can use it as a IV infusion according to the blood glucose level. So if it is less than 120, no insulin. Between 120 and 150, you have to give just 0.5 ml per hour of this fluid. And you have to use go on increasing like this, 2, 3, 4, 5, like that. As the blood sugar level increases, you can increase the rate. So you can also keep ready dextrose 100 ml with potassium to be given concurrently. So whenever you use this regimen of sliding scale intravenously, you have to go for dextrose with potassium to prevent hypoglycemia. At the same time, this will take care of all the increase in the sugar also. Now, what is the modified Alberti regimen? This is another method of controlling the blood sugar, which is asked in the examination. The first thing is you take 10% dextrose, not your regular 5% dextrose, 500 ml. Then you add 15 units of regular insulin like actrapid to that and add 10 millimoles of potassium chloride, and then use this mixture for at the rate of measure blood sugar every 2 hours, and then this is also called the GIK combination, that is glucose insulin potassium combination, which is also used for treatment of hyperkalemia also. And this is when the blood sugar value is more than 200, you can give 5 units per hour, or if it is less than 120, you have to stop or reduce the insulin, and 120 to 200 you continue at the same rate. So you have to give this at the rate of 100 ml per hour and then try to control the blood sugar with that. Then there is a newer regime used by the CMC Medical College, Vellore, to control the blood sugar. In Vellore, what they did is they took regular insulin, 5 units in 500 ml of 5% dextrose. Because it is difficult to get 10% all the time, you use what is available. So you take 5 units of actrapid in 500 ml of 5% dextrose, and then start it in the ward itself at 100 ml per hour until the time of operation, and check the blood sugar. If it is less than 70, remove this solution. Don't give this top insulin. Give only 5% dextrose for 15 minutes. After that, you check 71 to 100, only 5% dextrose again. Only start insulin after, if the blood sugar is more than 100, then only you start insulin combination. There you give only 1 unit of insulin and 100 ml of dextrose, 5% dextrose. If it is 151 to 200, 2 units. Like that, you go on increasing by 1 unit, and 1 unit of insulin for every 50 milligram more than 100 milligram with 100 ml of 5% dextrose. Now, why they have introduced this? This is much more easier way to use and control. And what equipment is needed for this methods? You require an infusion syringe pump or something like that. Whereas for the Vellore regimen, what you need is only a simple instrument like this. Can you tell me what is the name of this infusion set?
Burette.
Burette infusion set, usually used in
Pediatrics.
pediatric patients. Excellent, very good. So you use this, so the cost is very cheap. You don't have to invest too much on infusion pump and syringe pumps, and you can always discard the unwanted fluid and then refill it without any change in the IV set or anything like that. So that is the advantage by which they have increased this. So this is also asked in the examination, which you have to know about. So these are all the points I thought you should know with regard to your patient. It is not a discussion on how we are going to manage a diabetic foot ulcer foot or your vascular disease patient, or we are not going to discuss how you have to manage a diabetic patient coming for a major surgery. All these things are not indicated. This is more from the pre-anesthetic examination point of view. I thought you should know all these points so that you know how to manage a patient with severe hyperglycemia and diabetes. Okay, so we'll stop there. And any questions on this? The doubts you want to clarify?
No, sir.
Thank you, sir.
Okay.
Any doubts from the students?
No,
Any
no,
questions?
no, sir.
Sir. Thank you very much.
Sir, I'm Dr. Guru Sandhya here. It's such an excellent lecture, sir.
I am very happy that you have joined this session, and I happened to listen to your arrhythmias and perioperative arrhythmia. That was also equally very excellent, very well conducted class. I'm very happy you have joined the teaching of young postgraduates because I find the good teachers are becoming less in number, and I'm very happy you have joined the team. So we can continue to contribute for the sharing of knowledge with the youngsters so that we can produce good quality anesthesiologists. Especially oldies like me are dependent on youngsters like you for our safety as well as the safety of the public. So I'm very happy that you are also here. Thank you.
Okay, sir. Thank you, sir. Such an excellent lecture, sir.
Thank you very much, sir.
Thank you. Thank you.
And I wish a happy Pongal holidays for all our students.
Yeah, wish you all a happy Pongal. Those who are going home, enjoy with your family and have a nice Pongal. And we will meet next week.
And thank you, Guru
Next week
Satya.
will be hypertension and the setting of pre-anesthetic anesthesia. So like that, we have about 6 topics already planned. Hypertension, then it will be ischemic heart disease, then it will be obesity. I think I have sent all the details to Dr. Kamachi. He will be informing you about how we are going to plan those lectures. Okay, so please read about those things also. You are all answering very well, but if you read a little more and come, it will be much more interesting for you to, and you can question me also to find out whether I am telling you the right thing or not by reading. Okay.
And Sir has given one homework also. Today's homework is to remind, just a reminder for you, why diabetes mellitus is labeled as type 1 in Arabic letters numericals rather than Roman letters nowadays.
Yeah.
So students,
you can tell me the answer in next class. Okay.
yeah. Thank you, sir. Thank you. Can we sign up for this meeting, sir?
Yeah, please. Thank you.
Yeah. Thank you, Guru Santya madam. Thank you, dear students. Good night for you all.
Thank you, sir.